Hello and welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. My name is Jenna Morton. I'm one of 3 co-hosts for this series on behalf of the Canadian Premature Babies Foundation. I'm a career broadcast journalist and mom to 3 NICU grads, 2 of whom were preemies born at 32 weeks, who are now 11 years old. I live and work in Mi'kma'ki, outside of Moncton, New Brunswick. Preemie Chats is the creation of the Canadian Premature Babies Foundation, also sometimes known as CPBF. The foundation is a parent-led charity that helps families during and after their NICU time through education, support, and advocacy. You can see our website there on the screen, canadianpreemies.org. I hope that you'll take some time to visit the website after our time together today. You'll find a recording of this session as well as all of our previous Preemie Chats. You'll find our podcast, all kinds of resources, especially on respiratory illnesses around this time of year is an important resource to have. Most importantly, what you'll find at canadianpreemies.org is a community of parents and professionals who are working together to help our children thrive. Of course, we would love to have you join in the conversation today. Please let us know where you're watching from as we go through our discussion today. If you have questions or comments and experience to share, please do reach out and let us know in the comments what you're thinking, where you're joining us from, and what brings you to us, whether you are a healthcare provider or a preemie family or someone else in the industry. Please let us know where you're joining from and what brings you to us. Well, today's topic, I'm sure, is one that's going to have a lot of people wanting to share some thoughts. And it's a very interesting topic. I was thinking about the fact that, I'm fascinated by how fast our knowledge is expanding. And, they say it used to be that every 100 years we would, have knowledge doubled in the human race. And now it's every 2 years or even less that our knowledge base increases. And as that knowledge increases so quickly, what changes along with it? And that's kind of what we're going to talk about today through the lens of the NICU and preemies and neonatal follow-up. And to do that, I'm going to be joined by Dr. Jessie van Dyk, who's a neonatologist and medical director of the Neonatal Follow-up Clinic at BC Women's and Children's Hospital in Vancouver. Her work focuses not only on the experience of preemies in the NICU, but also on the experiences of the entire family touched by a NICU journey. She is committed to changing the way we think about supporting preemie families and follow-up care, and I am absolutely thrilled to have her join us here today on Preemie Chats. Welcome.
Hi, good morning. Thank you so much.
Thank you so much for the work that you're doing and the presentation that you've put together for us today. I know it's going to be one that a lot of people are going to be very, very interested to hear what you have to say. I'm going to turn things over to you and your presentation now.
Thank you very much, Jenna. I want to say thank you so much for inviting me today. It really is an honor to be here. My husband mentioned this morning that when I'm excited and a bit nervous, it's a bit like being on a walk with a Labrador puppy, squirrel, bike ride. So I hope that I can keep it together and really start a bit of a conversation today. As Jenna said, my name is Jessie van Dyk. I'm a neonatologist at BC Women's Hospital in the beautiful Vancouver. And our clinic is currently exploring this topic of how relevant the care is that we are providing, and how we can pivot in the future and really support families, but also continue to do the work that we feel is so important. And so if you'll bear with me a little bit, I want to take us back not only to the beginning of follow-up, but to the beginning of our field in general, and maybe explain a few of the things that have continued to permeate the way we do things. Then I want to just say a quick few things about follow-up care specifically in Canada. I want to explore a little bit with you sort of those outcomes of importance and who they're important to. And then I'm really, really hoping that we can start a bit of an actual chat back and forth, and that you will let me know some of your thoughts and comments along the way, so that we can help figure out, what the road ahead for us holds. I have to do the usual conflict of interest disclosure, and thankfully I have nothing to declare. And then I also really want to acknowledge, as a transplant from South Africa, I want to really acknowledge with gratitude that I live, work, and play within the ancestral, traditional, and unceded lands of the Musqueam, Squamish, and Tsleil-Waututh Nation in this beautiful Vancouver and BC. And I'm so grateful to be able to be here, and for the stewardship that these peoples have had of the lands. And so let's go to the very beginning. Where did this whole conversation start? And I want to take you back to France and Germany in the late 1880s, and a physician named Pierre Boudin, who had the idea for the human incubator when he saw a warming chamber for poultry in a zoo. And he approached the zookeeper and asked him to build him something similar, but that would be able to fit 1 to 2 premature babies, because this was one of the real struggles initially with helping premature babies survive the transition out of the womb, was how to keep them warm and keep them from losing all that body temperature, body heat. And so the first human incubator was born. And then Boudin approached one of his trainees, Dr. Martin Coney, and suggested that he take this on a bit of an exhibition, sort of a traveling roadshow, if you'll forgive the term. And so these human incubators were first displayed in Berlin at a fair, under the label of human hatchery. And then spread to different parts of the world. So you then saw them pop up at the New York World's Fair and Chicago and other places in Europe. Interestingly enough, when this idea was first floated in the UK and London, they suggested doing a sort of a similar exhibition. The mayor of London refused, and they actually had to travel across the channel with basketfuls of French babies to display in London. So I thought that was an interesting little factoid. Thankfully, they were not just about the showboating, but they also were very focused on establishing specialized units. And if you try and go back right to the history of neonatal care, it seems like the first of those units were started in the late 1880s, early 1890s in Paris. And there was the maternity hospital and the Clinic Tenière, where they really began to focus on not only having units where these babies would be cared for, but way ahead of their time, they also started thinking of specialized groups that would look after these babies. And these consisted of midwives and nurses. And over time, they would bring in other specialties, pharmacists, etc. So the birth of neonatology. I want to fast forward quite a few decades, and if you want some, nighttime reading, there's a special feature in pediatrics in I think from 2003, where Alex Robertson sort of talks about breaking up neonatal care in these 3 big epochs, where initially we were really concerned about just helping these babies survive, and they thought they could do that by concentrating on warming, feeding, and isolating them as much as possible to protect them from contracting infections. And then we swing the pendulum completely the other way, and we go into what they refer to as the heroic years, where we were jumping all in with, he says, therapeutic exuberance, and there was a spirit of innovation, but we were somewhat lacking in discipline. And it was a bit of the Wild West. And then from the 1970s, we began to mature a little bit more. We started introducing more RCTs in neonatology. And now we're beginning to talk a little bit more about longer term outcome. We're not just so focused on survival. And for me, I was born in the 1970s, so that doesn't feel like such a tremendously long time ago. I went looking to try and find sort of the earliest article I could find that talked more about development and longer term outcome. And this is from the mid 1970s from Montreal, so in Canada. But you can see even then when they're talking about longer term outcome, they're really sort of thinking very short, feels like short term for us, 12 months of age. And they were quite focused on things like, growing well, and then very distinct things, tangible things like central nervous system defects, such as, hydrocephalus, which is one of the complications of having a brain bleed. But there does begin to be a bit more mention of developmental assessments. And in this one, they use the Griffith's Mental Developmental Scale, which for those families that have been to the follow-up clinic is very similar to the Bailey that we use quite often today. And so you think 1970s, right? We've come a really long way. And I would argue, yes, we have. We have learned, and we still have a fair bit of way to go. And there still are some really nagging questions that we in follow-up haven't quite answered. And one of those that has become quite a topic of struggle for me is, which outcomes we consider important. And I know you've recently just had talks from Dr. Bolka about long-term developmental outcome, etc. But in the past, we've had this way of, trying to dictate which outcomes should have more significance than others, and which outcomes should have more relevance and should be more closely looked at. And then for some bizarre reason, we've classified others that can, provide just as much challenge to children and to families, and we've labeled these minor morbidities. And I would argue that, at least one, if not a combination of these, can cause a child to struggle in the classroom as much as one of the ones that we consider more of a major morbidity. And then when we're, trying to chew on outcome classification, this is one of those examples where, we've tried to classify outcomes. And some of the struggle with this is when you do research, it's always easier to have a very distinct outcome label and a very distinct classification. And it's even easier to analyze and look at when that classification comes with some kind of scoring system. So it's very enticing to gravitate towards something that we feel is quite distinct. But the question then becomes, who are these outcomes important to? How do we classify them? But also, who are they important to? Are they there to help clinicians in the NICU? And I would argue that this is one of the reasons we collect some of this data, is to provide some of that guardrailing for medical care in the NICU. We want to know if something that we thought had a good and a positive effect maybe has some unforeseen long-term effects that we didn't quite bargain on. But then, is that data that we're collecting in the clinic, is this also relevant to families? Because they are in that unit with the clinician and they're trying to make these really difficult decisions. And those decisions become even more difficult to make when the data that we present isn't what the family is looking for. It doesn't answer those questions about what kind of life their child can expect. And then I don't know that we've done a really good job exploring the child's factor in this and what might be important to them. Second question that we're struggling with quite a bit right now is, how long should this follow-up care continue for? Many clinics in Canada and in North America have historically had a mandate and have had funding to follow children for 2 years or 3 years. But I think more and more we're realizing that this just isn't, if we're going to do those two things, if we're going to do not just the data collection, but also provide a clinical service to the families that come to us for care, then 2 or 3 or even 4.5, it might just not be good enough. And I can show you many different publications that talk about that, but this was just one, and this is from Barbara Schmidt and the CAP trial investigators, where they were looking at the effect of giving caffeine therapy to premature babies to treat apnea of prematurity. And they had some findings at 2 years corrected using the Bailey scales of infant development, And then they found that those didn't necessarily correlate very well with what they saw when the child came back at 5. So a little bit of, word of caution for us. And this is another similar publication, and you don't have to be a neuroscientist to know what it is that they're talking about in this one. And then if I haven't convinced you yet, this is another study looking at the trajectory of children when they're seen at 2 and then when they're followed a bit more longer term. The things that we see at the 2-year visit and that we often talk about don't always give us all that information that families will need later on. And when this was a PowerPoint, they sort of dropped on top of each other, but that didn't come through on the PDF. But there is a treasure trove of information now about longer term school age developmental outcomes, more nuanced things that children might need us to support in childhood, and we're focusing very much on the preterm infant today. And I think more and more we're realizing that these children might have a very specific set of strengths and sometimes challenges, and that the stress and the experience of being in the NICU itself can lead to things that we might have to think about supporting quite long term in some children, and that this wave them goodbye and good luck at 2 or even at 4.5 really does a disservice to families. And this is just one of those articles. And we've talked a lot about developmental outcome, or focusing on developmental milestones, but we also have to start thinking a bit more of whether in providing a follow-up service to families, it also makes sense to be factoring in and building in a more consistent medical long-term screening and follow-up as well. And then we focused a lot on the child, and I don't want us to forget that the child is surrounded by caregivers and by a family, and that we cause trauma to families in the NICU. The NICU experience causes trauma for families, and we know that almost a third of families are at risk for developing an acute stress disorder. So something that happens quite quickly or quite immediately after that traumatic event. And this goes up significantly when we're just looking at mothers or the primary caregiver for the child, and that up to 2/3 of parents can be at risk for a more sustained post-traumatic stress disorder, a long-term pervasive struggle that families have to deal with long after they've left the confines of the NICU. And when we focus just on postpartum depression, we know that in the general population, the risk is about 10 to 15%, but that skyrockets to about 40% in moms of newborns admitted to the NICU. And we cannot forget about the fathers or the secondary caregiver, but often they are the ones sort of propping up the other parent in the moment, and their reaction can sometimes be a bit delayed, but we can't forget about that. And then there are certain groups that we have to pay even a little bit more attention to: ethnic minorities, immigrants and refugee populations, those that may not have as strong a support network around them. And you'll say, well, okay, well, why are we so worried about the parents' mental health? Well, we know that ability to bond with the baby and read their cues successfully helps us form an attachment with our baby, and that helps so many different areas, things like feeding success, a sense of parental efficacy, and that feeling of ease of parenting your child, of not being disconnected from it. And all of those things directly affect long-term brain development and eventual, if you want to talk about neurodevelopmental outcome. But then you look at, what we're able to do or currently doing in clinic, and this was a survey a few years ago of the follow-up clinics in Canada. At the time of the 20 clinics, there were only 3 that were consistently able to work parent mental health screening into clinic visits. And often the argument becomes a little bit, well, if there aren't enough resources in the community, then, what do we do once we've screened? And that just it isn't a good enough argument. A next facet of all of this is the language that we use or have historically used, and it can be very, weakness focused or disability or challenge focused, and there isn't often enough talk of lifting out strengths and celebrating the things that children are able to do. We can get a little bit focused on what the child isn't able to do in these visits. And so there have been different strategies to try and combat that and change our own language. And for myself, I'm so grateful for some of the mentors that I've had, people like Dr. Paige Church and Maureen Luther and Pat Madalena and so many others to really change the way we think about talking to families, and the idea that it's not just the things we say in the unit and in the clinic, but it's also the way we say them, and we can shape families' experiences by the way we talk about these things. So this is just one example of trying to change that language and focusing on more approach and talking about the F words. And the F words might be slightly different in your house, but in our clinic, there are things like fitness and function and friends and family and fun and future and the things that we want for all our families and our kids. And so you listen to all of this and you think, okay, well, we've pivoted, we've adjusted, right? And I say to you, it's still very much a work in progress. We just talk about Canada because we have a somewhat unique way of doing things in Canada or North America, if you want to talk about it like that. There are many other parts of the world where neonatal follow-up programs are not, don't look the same. There are parts of Europe where there are no neonatal follow-up clinics. You have a clear divide between families attending to participate in research projects or research studies, and then they would receive their care from their pediatrician in their community. But in Canada, we've tried to do something a little bit different. But when you look at the map of Canada, you sort of have this sprinkling of about 20 to 22 differently established follow-up clinics or programs across the country, doing sort of the majority of the work. And I want to just focus on BC for a minute because one of our particular difficulties or challenges is the fact that we have this wide geography. When you look at the size of BC, I've tried to plot just the last 3 months patients attending follow-up clinic here in Vancouver, and you can see that they come from so far and wide, right up to the Alberta border and all the way up to the Yukon. And this expectation that families are going to travel to come and see us, is this an outdated notion? Should we be thinking of trying to not centralize this as much, go out to meet families where they are, or try and establish clinics in their own communities? So this is one of the challenges that we face here in BC. And I'm so grateful that this conversation is more and more including families and parents and what are important to them. And this is just, one example of that. This one, the Parent Voices Project that many of you might have been involved in, is really beginning to help change some of the language that we use and some of the outcomes that we explore. And families helping us find that rhythm or that middle ground, right? We have to continue to collect, I personally think, some data, but we also have to start shifting that data to something that is more relevant to families. And this is just another one talking about that same having that same balance and using some different language. And you'll say, well, Jessie, that's great. You've said a lot, but what is your point exactly? And so I would say at the end of the day, please bear with us. We're still adjusting. I personally think that neonatal follow-up care, especially in Canada, is still quite relevant, but our outcome definitions remain a bit of a problem and need some more exploring. And the parents and caregivers and families have to be part of that solution. They have to be at the table with us, redesigning what we do. And we've tried really hard to do that here in BC. But we are more and more realizing that we need more, potentially, not less. So longer follow-up, potentially more sophisticated, more individualized, maybe. We feel it has to include at least some general medical screening because there often isn't as much knowledge and experience in our community and maybe not the time. If you have 15 minutes to spend with a family, then, you know, maybe there just isn't time to focus on all these different facets that need attention, and that partnerships are really key. So we need to start partnering with families, but also with communities and maybe with the school system, break down some of those silos between different services and different centers to try and solve some of these conundrums. And so I'm hoping that I'm pretty much done talking at this point, and I'm really hoping that somebody has some comments or some questions, and that we can explore this a little bit more together. Thank you so much.
Oh, thank you. There's so much in there. It was fantastic. I was furiously writing down notes to myself as you were talking. I'm wondering if you could maybe chat a little bit about, I think what was jumping out to me a lot was this idea that we need to find ways, and I think this is true in most aspects of our lives right now, not just when it comes to relationships between healthcare providers and parents. But I think as a society right now, we're very much set in this kind of us versus them mentality, and that, you know, bringing up the word partnership and the language choice, and what can we be doing on both sides as parents and as healthcare providers and researchers to really build those trusting relationships?
That's a really good question. I think including families in those conversations much more and maybe earlier. You know, as healthcare providers, we sometimes have very structured ways of doing things. We have the tick sheets of things we want to tick and talk about, but we're not always very good at just sitting down and having a conversation, or even admitting that sometimes we maybe don't have the answers, and we're looking to families to help us try and find some of those. I think in our old maybe a bit more patriarchal way of doing things, there's the physician needs to have all the answers and know exactly what's going to come next and what's going to happen and what the risks might be. And sometimes I think we have to do a better job acknowledging that we still don't have many of those answers, and that families can help us look at that. I think we have a very specific set of challenges in the follow-up clinic where we do want to continue. You know, many of our clinics started off just as pure data collection reservoirs where we were collecting data because we really want to do better. We were continuously trying to do better for the families that we look after in the NICU, and the follow-up services sort of helped us do that by that knowledge translation back to the unit. We haven't always seen the need, unfortunately, to translate some of that knowledge back to families as well, especially families who have helped collect that data. And so how do we start a bit more of that relationship where you're not just coming to give us your data, but you're also coming to receive a service from us? And I think that's something that is a little bit unique about the
I wonder how you kind of envision the next 5 years of this happening, specifically in Canada, because, you know, you can't kind of make general assumptions for the world, but in terms of what might change in how we think about neonatal follow-up?
That is a really great and a really big question. And it is something that our clinic has been struggling with for a number of years now. And we've recently started a process where we said, okay, instead of trying to tweak this system right, instead of trying to, make little changes to try and, stop gap and fill up some of the Swiss cheese, if we had to wipe it all away and start fresh today, what would make sense? And we're in the process right now, and we don't have the answers yet. So, but what we did do right from the beginning was to include families in that planning and in that conversation. And when we had even our, we started right at the beginning with a vision and mission planning day. And we had families, and we tried really hard to have different types of families and families with more of an Indigenous background too, to say, even right from the beginning, right from that vision and mission, some of the language that we use and we mean well, and we talk about things like thrive and flourish, and we don't realize as clinicians that even those words that we think are so positive and great, empower was another word. It's not our power to give, those language things right from the beginning are quite important, and we don't always think about it because we don't have that parent lens. So include those families right from the beginning, and it sort of shifts your thinking a little bit. And so, we talk about this dichotomy, the data collection and the service provision, but there's also the dichotomy between the clinician and the families, and then the child with the family. So I think having more conversations, and then there's this idea that if there's not something, then we shouldn't ask for it, right? If there aren't enough resources, then we shouldn't screen for mental health because we can't do anything about it. Or if there aren't enough early intervention resources in the community, then why are we perhaps referring, or we should try and fill that. I think there's also the responsibility on us to advocate and to keep asking and to educate and to go out and do maybe a bit of outreach and to present at conferences and to keep talking about this and keep presenting with families at the table. Why do we have medical conferences where families are not present? Why do we have neurology? I recently went to a neurology conference where they were talking about seizure treatment in the NICU, but there were no neonatologists. So, we live in such a siloed healthcare system, and it's really frustrating. So that's something that I would really like us to see, is to start having those conversations across those silos too.
I think that is so important, and I see it, I think, happening more and more, and hope that over the next several years we will see that increase in the impacts of it. I wanted to share, we have a comment from Kim, who's joining us, and talking about, from the standpoint of funding, and how tricky a part that plays in these kind of conversations about, how do you expand things? How do you make changes when you're just trying to survive with what you have? And I'm wondering if you have any words of encouragement for people out there who are wanting to make a change but not sure how to make that happen.
I think the more voices there are, the better we're heard. And my husband likes the saying, the squeaky wheel gets the oil, or the whatever it is,
The grease.
The grease. And I think we need to say this more. We need to talk about it more. We need to be more vocal, because there's lots of talk about breast cancer screening, and there's lots of talk about the opioid crisis, and I don't think there's enough talk about this. There's not enough people talking about it and talking to the people where it matters. We are trying to convince our hospital leadership that this is a worthwhile investment. This is a resource that is going to pay off in the future for families. Talk to your teacher about your child being born premature, and the specific expectations that you have for the supports that they will receive in school, and don't be afraid to to voice your opinion, because often the parents will know more about the child's strengths and needs in school than many educators know about what preterm children need. And then talk to your hospital foundations, or if you're donating, express your desire that this goes to that specific source. Because I think the more, hospital administrators and the more politicians and the more school people hear about this conversation, the more topical it becomes. Because right now, some of the arguments are, well, this is a really niche area and this is a really small population. But when you look at, we recently did a calculation, and it was something like 14% of children going into kindergarten in the next school year will have been born preterm in BC specifically. And I would argue that that's not actually a small percentage. And we see that continue to grow over the years. So I do think, there's advocacy, but there also needs to be conversations. When we go and speak to the foundation, we need to take families with us, because we can make the case, but they can make the case so much better.
I think it was really interesting. One of the slides you had up talking about, how who should be involved in the questions and what was happening. You had the clinicians and the parents, but you had the child. And I think, in doing a lot of these preemie chats, there's quite often adult preemies who are watching and who chime in the comments to share their experience from an adult point of view of being, a premature birth. And I think that that's such a fascinating voice that we haven't heard a whole lot of in the past in this conversation. And, and I think back to, you were talking about those kind of three different generations of NICU experience we had, where it was, the hands off and then the heroics. And I remember the first World Prematurity Day event that I took part in, the mayor of our city was there, and he was like, "Oh, yeah, I was in the NICU. I was there for 3 months." And he always felt this disconnect from his parents because they couldn't visit him because of it was in the hands off era. Yeah. And he didn't think of it either, though, as really part of who he was, because it wasn't something they spoke about, because I think it was such a traumatic thing. And I think the more that we speak about all of these nuances, the more that we can start to hear those voices of what it means for the infants that we're talking about as they go through life.
Yeah, exactly. And I'm so happy you mentioned that. And maybe I'm speaking a little early now, but we're hoping to work with the Canadian Premature Babies Foundation to distribute a bit of a survey amongst families, but also a separate one amongst teenagers and adolescents and maybe adults who were born premature, to really explore some of the themes and some of the things that we are not currently supporting very well, and really are at a bit of a loss as to how to support. Instead of putting the cart before the horse and trying to design something that we think works, we want to go right to the source and say, if there had been supports, what would have been the things that would have made a difference? And hoping that out of that maybe comes some focus groups and some real conversation about what was the experience in the follow-up clinic, what did add value, and what was maybe not very valuable. And when it stopped, it breaks my heart sometimes when we say goodbye to families at that 4.5 visit. And, in the back of my mind, I'm thinking, I wish I could support you longer. I wish I could stay involved longer. I wish I could be more effective. I wish I could, because I have even the slightest inkling of potentially what you might struggle with moving forwards. And yet we have this artificial line in the sand. And that's, you think of children who have, for example, if you get a diagnosis of insulin-dependent diabetes, you are followed, by a pediatric service, and then you are discharged or transferred to an adolescent service, and then an adult service. And there are many of these things that are that well supported. And I think care to preterm children and their families is not something that currently works that way. We sort of, we've collected this data up to this point, and now we kind of wish families well. And this is just what we've been funded and mandated for right now. So we really are fighting to try and change that.
I think, as a parent whose children, like I said, my preemies are now 11, and I very much see that difference of, we were discharged at age 2 because we didn't have, a host of things. Even though one of our children has CP, it's very mild, and it was just your family doctor is all you need now, and you get some OT when you go to school in a couple years, and the difference between even entering school and now we're in middle school years, and that idea of what you need when your preemie is born and age 2 versus what you need at as they're tweens and teens, even if they don't have a host of things, you still wonder how much is playing into how they're learning in school or how they're developing socially. And so I think it's so wonderful from a parent's perspective to know that there are researchers and clinicians like yourself who are really trying to dig into what else can we do now that we've got a handle on some of this early stuff.
Right. We've collected that data. Now it's time to give some of it back, right? And to act on that data. You talk about specific challenges, and something that we've come across more and more now is this idea of, we want to red shirt or delay school entry for preemies. But, to me, it seems like such a clear issue where if you should have been born in January or February or March, you should have gone to school in that year. Now you're born in October or November. It not only were you born premature and your brain needs that extra maybe time to mature to that corrected age, but we're actually now expecting you to go to school a year early if you think about it. And it's mind-boggling how difficult that conversation sometimes is, because the pushback is, well, we will support anyone and everyone in the school system. We will find the supports that work. And unfortunately, that's not always true, because many of our preemies are not the disruptors in the classroom. They're not the ones that make the teacher's life more difficult. And so often they're missed, and the things that they need are not recognized early. So I think, some of those conversations we can help be part of, but we can only do that when we're still involved.
I think that's a great spot for us to end our discussion today. And I want to thank you so much for taking the time, and for everyone who was chiming in. And if you have, if you're watching this on the replay or you haven't had a chance to ask a question, please, feel free to drop them in the comments, and we do try to come back and take a look. But thank you very much for joining me today, Doctor.
It was my pleasure. Thank you so much, Jenna. Goodbye, everybody. Have a lovely Thanksgiving weekend.
You too. Again, my guest today was Dr. Jessie van Dyk, a neonatologist and medical director at the Neonatal Follow-up Clinic at BC Women's and Children's Hospital in Vancouver. Again, you can watch this on the replay on our website, canadianpreemies.org. I would like to thank you all for taking the time to join us, and I would like to thank our sponsor for this series as well, AstraZeneca, for their ongoing financial support. And a reminder that we are here with Preemie Chats every Friday afternoon at 1 p.m. Eastern. I hope that you will join us again, and until then, take care.